I'm very excited to welcome to the stage Elizabeth Nielson and Jeffrey Guss. Elizabeth Nielson is a clinical psychologist and postdoctoral fellow in the Behavioral Science Training in Drug Abuse Research Program at NYU, Rory Mayers College of Nursing, and presently in training to become a therapist in the upcoming Phase 3 trial of MDMA-assisted psychotherapy for PTSD. Her program of research includes qualitative and mixed method projects designed to further understanding the phenomenology and mechanisms of change in psychedelic medicine. Jeffrey Guss, MD, is a psychiatrist, psychoanalyst, and researcher with specializations in the psychoanalytic therapy and the treatment of substance use disorders. He is co-principal investigator and director of therapist training for the NYU School of Medicine's study on psilocybin-assisted psychotherapy in the treatment of cancer-related existential distress. Please welcome Elizabeth and Jeffrey.
Well, thank you so much for coming, and it's so great to see such a huge turnout and interest in psychedelic therapy, and I want to thank MAPS for inviting Elizabeth and me to do this. So we're going to be talking today about psychedelic therapy and the process of psychedelic therapy for the therapist, not so much for the patient or for the drug. We talk so much how do psychedelics work, what happens to people when they take psychedelics, but we're focusing today on what happens for people when they become and practice psychedelic therapy. And I want to start by trying to define psychedelic therapy and differentiating it from many of the other extremely valid, important, and wonderful ways that psychedelics can be used by human beings. Psychedelic therapy refers to a collection of psychotherapeutic processes that are facilitated by psychedelic agents. So in this way, it has a connection to psycholytic therapy, as described by Hans Karl Leuner and a number of other practitioners who saw the therapy as a core part of what was happening and the psychedelic agent as facilitating it. Now, in the work that we did at NYU, we were trying to facilitate both a psychodynamic or psycholytic process and a psychedelic or a spiritual or mystical transformation state. So both of those are part of what we were doing, but what Elizabeth and I are trying to do is define what's the role of therapy in supporting this process and helping make it happen. Because in a way, if you really do believe in set and setting, then the therapeutic relationship is the most powerful part of the setting imaginable when you're working in this context. So here, psychedelic use is different than using psychedelic as a probe into neuroscientific questions of how the brain works or how they work in the brain, as a facilitator of creativity or personal growth, as part of a shamanic ceremony or part of a trance dance rave type experience. And psychedelic therapy is defined by treating a particular condition. In our NYU study, we were looking at cancer-related existential distress, but also people are looking at PTSD, obsessive-compulsive disorder, depression, cigarette smoking. And all of these are examples of psychedelic therapy that's used to treat a problem that's defined by the DSM-5 in one way or another. So psychedelic therapy, as it happens above ground, occurs in a research context. And that is the only type of psychedelic therapy that we are going to be discussing today. There's lots of valid and important psychedelic therapy happening elsewhere, but that's not our area of exploration today. And with that said, it's defined by many of the parameters and restrictions that academic research brings. And it exists within the discourses of psychiatry and psychology using the DSM-5 models of psychopharmacology. And the therapy is done by psychiatrists, psychologists, nurses, and social workers. We use a classic psychedelic therapy model that was defined by Groff and Richards, and I'm going to talk about more detail about that in a couple of minutes. It's an admixture of psychedelic and psycholytic intentions, and although there are manuals, much of what happens is nonetheless quite intuitive. So there's 3 parts in this model, known as the Hopkins model of psychedelic therapy. We learned it in considerable detail in working with Bill Richards, who shared with us what he learned and for his 25 years of experience in doing this work. There are the preparatory sessions during which you build rapport, you do psychoeducation, and you define and explore the intentions. Then you have the dosing sessions, and there's the couch, the eye shades, the music, and these are all classic parts of psychedelic therapy. The inward focus of the journey, therapist restraint, not doing very much, giving minimal amounts of support as necessary in order to support the development of an intense, meaningful process. And then the integration sessions where you have active listening and helping the person bring their experience into day-to-day life. So again, this kind of research in academic settings is set out to treat a specific condition. It maintains all the framework and covenants and responsibilities that you have in doing therapy in any other way, in any other setting. So there's nothing underground or relaxed or alternative about the boundaries that you use and the structure of the relationship. So again, there is a power differential. The therapist and the patient are not peers, are not equals. They each have their roles, and there's certainly a lot of mutuality in their roles. But the normal dynamics of a patient-therapist process are there. There's not an underground context, but it does exist in an underground, in a sort of a traditional medical model, psychological world of inner conflicts, underlying issues, self-understanding, self-transformation, emotional catharsis, existential concerns, and the centrality of relationships. So all of these are themes that are present in traditional psychotherapy, and they come out and are explored likewise in psychedelic therapy. So with that, I want to close my portion of the presentation and turn it over to Elizabeth, who's going to tell you about the research project that is underway right now.
Thanks, Jeff. Thank you, everybody. I want to start by just reiterating what Jeff said earlier, which is that it is so wonderful to see all of you here and so much interest in this. It is absolutely heartwarming. I am grateful to all of you for being here and showing up at this conference, making this happen. So I'm going to tell you a little bit about a research project that I designed in collaboration with a few other people in order to look at how psychedelic therapists think psychedelic therapy works. And this isn't necessarily the be-all, end-all ultimate explanation of how it works, but it's looking at a specific group of people for their take on how it works. So how do they conceptualize and understand it? So the study that is currently underway right now is designed in collaboration with Jeff Guss right here and Steve Ross from NYU, as well as my colleague Honoria Guarino from National Development and Research Institutes, who's an anthropologist. And we had some collaboration on the design of the study from Roland Griffiths and Cody Swift as far as making, designing what our questions and interview protocol would be. So this is really a collaborative effort by several of us who are within the psychedelic therapy and research world. We got our IRB approval. We went through all of the steps of writing this protocol and started some recruitment in order to find out really what, talk to psychedelic therapists and be able to find out how they conceptualize this therapy working. So our project, again, is to look at we're only looking at psychedelic therapists who are working in academic US-based research institutions. So those are our parameters. It's limited. You saw a bunch of logos on one of the slides previously of the institutions, some of the institutions at which this therapy is happening. I think there's only about 7 in the United States. And our rationale for doing this is a couple things. We know that this first generation of therapists that are working right now in the research settings are unique. They're highly inspired people. They're sort of writing the manuals themselves as they go along. There's a lot of feedback, a lot of collaboration. It's a very small group of people, people that are sort of at the forefront of beginning to practice psychedelic therapy in academic settings. So we think that there are a few norms at this point, and we want to learn from this group how they conceptualize this therapy working before those norms are really established. They're sort of teaching themselves. We think that the work of the current therapists will sort of create a template for therapy to come. And as psychedelic psilocybin therapists ourselves, we're sort of uniquely positioned to investigate this topic because we have the personal experience of being psilocybin therapists ourselves, as well as then being able to go back and sort of ask critical questions of it. So for qualitative research, that's an interesting positioning of the researcher, not as somebody who's coming in as an outside observer of the research topic and research subject group, but as somebody who's part of it as well. So a little background in basic clinical research. If you're looking at, for instance, an SSRI for a depression study, you'll see a very sort of simple additive relationship where you're giving somebody psychotherapy and then either a placebo or a medicine, and you're subtracting result A from result B and blaming the difference in those effects. Hopefully, all other things being equal as they're supposed to be in a clinical trial, the difference between groups should be accounted for by the presence or absence of the medicine. Right? Very simple, straightforward equation there. What we think is that in psychedelic therapy, you're creating this unique setting with the therapists are creating this unique setting in which the medicine can do its work, or the person can do their work with the medicine, and so that the results that we're seeing are more the results of an interaction effect between the psychotherapy and the medicine itself. So our specific aims here are to highlight the role of psychedelic therapy, to describe how therapists conceptualize certain key phenomena in psychedelic therapy that are already outlined in the literature on psychotherapy in general. And we're going to get into those in just a second. And to start coming up with a preliminary model of how psilocybin-assisted therapy works as the therapists understand it and talk about it. Okay. Again, I touched on this before, but our recruitment structure involves just contacting the principal investigators of existing research studies, scheduling interviews with some of those therapists on their teams that have a substantial amount of experience with providing psilocybin-assisted therapy. And right now we're at an interim analysis of our data. We've collected 6 interviews. We've done a little interim analysis of the first 4, and we'll continue to collect interviews, probably another 6 to 10 interviews or so until we've got a really good little group of them. So the stuff that I'm going to present to you today is based on the interim analysis. It's a way for us to look at our first few interviews, maybe decide if we want to make any changes to our interview protocol, if there's questions we want to add, things that seem to be coming up that we want to ask about more in depth for later interviews. We can do that based on what we're getting from the first few interviews. And it's also a way for us to see if later interviews coming in are adding substantially more new ideas to the body of data that we already have, or if we seem to be starting to reach what's called saturation, which means we're basically, we've seemed to be having covered most of the major points already. So these key phenomena are phenomena that are outlined in the research on psychotherapy, the general literature. We know that therapists in psychotherapy do work on building rapport and alliance, and talk about transference, and they talk about the use of touch or the not use of touch and why that would be appropriate or not. They talk about boundaries in the therapeutic relationship, whether the whole question of whether or not it's okay for a psychotherapy patient to call their therapist or email their therapist. Those are boundary issues. There's a lot of literature on self-disclosure. How much does a therapist say about themselves to a patient? Expectations. For the therapist's expectations of the patient and of what good therapy looks like can also play a role. And then one that we sort of added for this is integrating difficult experiences. We know that difficult experiences can occur while someone is actively under the influence of a psychedelic medicine, and we wanted to ask about how those difficult experiences get integrated. And we know from other literature on psychedelic use in other settings that may be an important phenomena. So I didn't put these 2 in bold by accident, actually. It looks like a typo, but it's not. I'm going to just give you a little bit of details of some of the things that we found out about 2 of these key phenomena. Unfortunately, we're a little short on time, so we're not going to go through all of them, but I picked these because I think they'll give you a little bit of a sense of what we're finding so far, and how these phenomena in psychedelic psilocybin therapy are going to be perhaps different or similar to the way that these phenomena play out in other kinds of psychotherapy. So let's talk about transference. Transference is, in general, is the idea that the patient comes into a therapy situation with a pre-existing baggage of unconscious material, and they then project that onto the therapist and sort of transfer it onto the therapist, and then can use that to work out whatever is going on with their problems. Is that a 5? Yes. What? 5 until questions. Awesome. So we asked therapists about 2 kinds of transference in psychedelic therapy. We asked them about transference, the patient's transference to themselves as a therapist, and we also asked about patients' transference to the medicine. So you got this powerful medicine in the room that's playing a huge role in therapy, and there can be a lot of, people have ideas about it, people have pre-existing knowledge about it, people have guesses about what it's going to be like, maybe they had an experience with something similar a long time ago, so they're coming in with some expectations. So that can also be another type of transference that we're exploring that can come up in psychedelic therapy in general. So what our participants so far have said about transference in general is that it's something that develops rapidly in this intensified short-term therapy situation. It tends to be positive and can require a little bit of reality testing and sort of, helping a little bit of effort to help the participant or research participant or patient understand the therapist as just, a regular human being and not, some magically built up person. But since the therapy is short term, it does not play a major role as it would in traditional psychoanalysis, where the transference is something that you're actually working through, and that's considered part of what's therapeutic. One of our participants said of transference to the therapist said, it's all amplified. All processes going on are amplified. If the patient would normally experience positive transference, it's just going to be a very positive transference. Sometimes it can get to ridiculous levels. You have to do a little reality testing. I don't think I ever ran into any serious negative transference. Okay. So negative transference could be something like the participant being, being very angry with the therapist, hating the therapist, not liking the therapist, that kind of stuff. So we haven't seen that yet. And then to the psilocybin medicine, people may have sort of negative, existing, anxious transference to the medicine. They maybe have anxiety about taking it. It could be seen as a facilitator of a very profound experience and something that people have a little bit of trepidation about. A lot of people in our studies have no pre-existing experience with any kind of psychedelic. They're psychedelic naive, so they may have just fears about it. One of our participants said they think of it as a medicine, as a drug they're taking, and they know it has powerful influence on their psyche and their brain and their emotions, but they don't seem to relate to it as anything other than a chemical that is providing this kind of experience. Okay. So this is the kinds of things that we're hearing from our therapists about transference. I'll tell you a little bit about what we found about self-disclosure. So self-disclosure means, again, the therapist's own use of talking about themselves, essentially, and it could be self-disclosure like, yeah, I live in that neighborhood too, or I'm interested in art history as well. Or it can be self-disclosure of what's going on for you as a therapist in the room at the moment. So I could say something like, when you said that, I felt really sad for you having gone through that experience. How does that resonate? Things like that, right? So in the moment self-disclosure. So I will tell you a couple of questions that we asked. Let me get back to this page. So we asked therapists how much and why they choose to engage in self-disclosure during psychedelic therapy, and how it might differ from their use of self-disclosure as a therapist in other settings. Overall, what we found so far is that it doesn't seem to be too different. Perhaps there's a little bit more, people are a little bit more relaxed about self-disclosure. but it's not too different. The guiding principle, just as in other kinds of psychotherapy, is the participant's needs. So what's actually helpful to the participant to hear as opposed to the therapist just wanting to talk about their life. We want to make sure that it's useful. And therapists talked about wanting to be open to self-disclosure even if it's not, even if they don't engage in so much of it. So they may say something like, hey, I'm willing to tell you about myself, but really we have a short amount of time and we want to focus on you and your story and why you're here. I will read you one final quote from this. One of our therapist participants, just speaking exactly to that note, said, "I'm willing to be open. I don't have any dark secrets I'm hiding from you, but our time is limited and we've got to get you ready for your psilocybin session." I'm going to end here and we will go to questions. We've got probably about 4 minutes left for questions. So, thank you.
Sorry, the questions will be at these microphones in the aisles, so please keep your questions as concise as possible, but you can line up here.
Can I ask? Is it possible? It is?
Okay.
Does it sound like it's on? Yeah.
Go ahead.
Thank you both. I'm not currently, but I was one of the head guides at Johns Hopkins in the Psilocybin project, working with healthy volunteers. And in with every single volunteer, they wanted to know my experience with psychedelics. It came up at some point, and I'm curious what the therapist that you interviewed shared about that particular type of self-disclosure when it came up.
That's an excellent question. Thank you for bringing that up. We did not ask therapists about their personal experience or how they dealt with that question. We made an executive decision to exclude that particular topic from this interview and focus it on psychotherapy processes. I do believe that is a very valid question and subject to be explored, but it was excluded from this study. So, thanks. One, and then over here.
Okay. You said that you understood the difference between first generation of therapists and second one. And the first was passionate and charismatic or doing with enthusiasm, right? Do you include it in the manual? Can you include it? Maybe this is what really works.
Yeah, I think one of the goals of this study is to be able to use these findings to help design future training programs and understand what's important and what to look for and what kind of qualities to develop in future therapists in training. And I don't mean to say that it's generations of psychedelic therapists that come later will be in any way not as wonderful as the present group, but there will be differences just because there will be existing norms and manuals. But we hope that this information will help inform.
Right, but my question is, do you understand the paradox that the kind of qualities could be fully included in manual, and it's also, if you put as better manual will do, that maybe you will less make better therapists because they will be studying by the manual, not by the experience.
Right.
Yeah.
I think it's a good example of how being involved in a research context puts a parameter and a requirement into the work that we do that is artificial and that constricts rather than offers freedom. I think what we've tried to do in all of our manuals is have something which allows a certain amount of uniformity for the approach from one participant to another, and yet maximizes the role or the place for creativity and the particular personality of the therapist. But it's a contradiction. It is a paradox of doing this kind of research in an academic research setting. Very much.
Thank you.
Thank you. We're done. Okay.
Okay. Wow.
Later.
Thank you. Thank you.